Okay, so I guess I'm introducing myself. I'm Linda Carlson. I'm a clinical psychologist and a professor in the Department of Oncology at the University of Calgary. Um, I'm also the past president of the Society for Integrative Oncology. So today I'm going to tell you about some of the work we've been doing through SIO with ASCO, the American Society for Clinical Oncology, on doing some, evidence reviews and clinical practice guidelines around recommendations for integrative therapies. So I'll just do my land acknowledgement. So I personally am here in Canmore, Alberta, which is the traditional territories of the people of the Treaty 7 region in southern Alberta, and this includes the Blackfoot Confederacy with the Siksika, Piikani, Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, whose land I'm currently on, and this includes the Chiniki, Bearspaw, and Wesley First Nations. I acknowledge the many Indigenous peoples in Canada whose footsteps have marked these lands for many generations. I'm grateful to the traditional knowledge keepers and the elders who are still with us today and those who have gone before. And I do this land recognition as an act of reconciliation and gratitude to those whose territory we reside on. So today I'm going to introduce integrative oncology. It's sort of a subspecialty of psychosocial oncology. It sort of is in the no man's land between psychosocial oncology and really, mainstream oncology, as many practitioners are medical professionals, oncologists. Just introduce you to the Society for Integrative Oncology, if you haven't heard of us. And then I'm going to review recently published clinical practice guidelines that have come out over the last couple of years on pain, anxiety, and depression and fatigue specifically. And then I'm going to show you these kind of really cool interactive continuing education modules and implementation tools that have been developed along with the guidelines. And I think they're pretty neat. Hold on, I've got a reminder here that I'm being recorded. Okay, there. So integrative oncology is defined as a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural health products, and/or lifestyle modifications alongside conventional cancer treatments. So you can see some overlap with psychosocial oncology more broadly. The aims are to optimize health, quality of life, and clinical outcomes across the cancer care continuum, and to empower people and prevent cancer and become active participants before, during, and beyond. So the entire spectrum really of cancer care, including prevention. Some important definitions in the sort of always changing landscape in this area. You may have been familiar with the term CAM, or complementary alternative medicine, which has now more transitioned into integrative medicine or integrative health. And that's because of the distinction between the words complementary and alternative. So when we talk about complementary therapies, these are products, procedures that aren't traditionally part of conventional medical care, but the key is that they're used alongside conventional care. So these include, again, natural health products, mind-body therapies, exercise, nutrition, all kinds of things like that. Whereas alternative therapies they could be the same kinds of interventions, but they're generally unproven or not having as much research. But the key here is that they're used instead of, not alongside. So when we use the term alternative therapies, we mean people who are foregoing their chemotherapy or their surgery that's recommended and going to a clinic in Mexico or Germany and trying something else that generally is expensive and unproven. So these are not part of integrative oncology care. And so I hear people still using the term alternative therapies, but I think, in this space, we need to be careful, try and use the term complementary therapies or integrative therapies. So here's a little fun survey. What percentage of people with cancer do you think use these complementary therapies? And you can put your answer in the chat. Is it A, less than 10%? Is it B, 25%? C, 50%? Or D, more than 75%? So let's just see what we've got in the chat here. I see a D. Anyone else? A C. Oh, a couple of D's and C's. So I'm seeing mostly D's and C's here. You guys are actually totally right. But there's some nuance around that. So, oops, can't advance the slides when I'm looking at the chat. I still can't. Okay. There we go. So the actual numbers, when we look across all patients, all points in the spectrum, is the C, 50%. So there's newer meta-analyses actually globally that show an average of around 40 to 50%. And in Canada, we were looking at 48%. That's about a decade ago, but it's actually been pretty stable, if not growing. But there are certain populations where it is higher, like among 75%. For example, in breast cancer survivors, it's one of the highest numbers. So we did a survey also locally at the Tom Baker Cancer Center and found a similar number. Again, this was back in 2012. We've done a couple since then, and it fluctuates a bit, but it stays around 50% use. And this is use since a cancer diagnosis. So women are more likely to use complementary therapies, younger people with higher education and living with cancer longer. So a longer time since diagnosis. The most popular things are natural health products like herbs and vitamins and supplements. And people are using these to improve their quality of life, enhance their immune system, increase feelings of hope. And there's a subset who are hoping it will help cure their cancer. Although within the field of integrative oncology, there's not a lot of evidence supporting that claim. So I talked about the sort of areas within integrative oncology, lifestyle modifications. So that's largely exercise, focus on sleep and nutrition, the mind-body practices that many of us in psychosocial oncology also do, like relaxation, meditation, hypnosis, also things like yoga, Tai Chi, Qigong, and the natural health products. And so these are used taking into account patients' values, preferences, rights to choose, their culture, their tradition, of course, the research evidence, and also clinical experience with these different interventions. So within lifestyle modifications, as I mentioned, we've got exercise, physical activity, diet, sleep, and stress management, which we would consider foundations of wellness. We may also put in things like social support and, sort of the basic foundations that everybody needs to practice, and then the mind-body therapies. So the most well-studied would be mindfulness meditation, yoga, acupuncture, Tai Chi, Qigong is beginning to garner a lot of evidence too, as you'll see, and natural health products like vitamins, minerals, and different botanicals and herbs, dietary supplement. So the Society for Integrative Oncology is an international organization whose mission is to advance evidence-based comprehensive integrative healthcare to improve the lives of people affected by cancer. It's a really nice organization, and the thing I like about it is the interdisciplinarity. So there's providers of the different complementary therapies, as well as nurses, psychologists, lots of different medical folks, and also a large group of patient advocates. So I've been involved since about 2013 with them and just finished a term as president. And we hosted the conference last year in Banff that perhaps some of you are at. So again, we're founded we just celebrated our 20th anniversary. It's the premier multidisciplinary professional organization for integrative oncology. We're now actually closer to 600 or 700 members. And I mentioned the mission. And we have a commitment to rigorous scientific research and evidence-informed practice. So you can check it out at integrativeonc.org. Of course, it's always great to join as a member. There's lots of different member benefits. You can find those on the website. And now I'll turn to the guidelines. So there's a bit of a history to the guidelines within SIO, and I first became involved in about 2013, as I said. Our first guideline we did all by ourselves, which was a ton of work, we realized, and we focused on all integrative therapies during and after breast cancer treatment for all symptoms. So this was a huge guideline that first came out in 2014 in the Journal of the National Cancer Institute. And got quite a bit of uptake. And I don't know if that citation number is accurate, but, a few hundred citations in 2014. And then we were asked to submit to the journal CA, the Cancer Journal, update these guidelines in 2017. And this is a very high impact journal and, again, was even more highly cited. And so we were seeing that these kind of guidelines, there was an appetite for them. They were quite successful, and we wanted to kind of take it a bit further. So in 2018, we brought the guidelines to ASCO, and the strategy here is that ASCO is the largest mainstream oncology organization in the world. They have over 60,000 members worldwide, and they're seen as a very credible organization. So we wanted to kind of partner with them and bring them on board with some of these recommendations. So in 2018, they endorsed our guidelines, saying the recommendations from SIO are clear, thorough, based on the most relevant evidence. So it's great to have the ASCO endorsement. From there, we wanted to take it a step further and collaborate with ASCO on creating guidelines. And so we were able to get a grant from a private foundation for a series of guidelines. And I think we got that grant back in 2020. It was 500,000 US dollars. And it was to support 5 different guidelines. And so these are the ones that we chose. And so far, we've finished the first 3. We're working on sleep. And actually, we're not quite sure what the 5th one is going to be yet. And so the way that we work it is there's a clinical practice guidelines committee of leaders in SIO from different backgrounds, so a few past presidents, current president, that kind of thing, who sort of came up with all the procedures around how we're going to create these guidelines, what are the the methods, how are we going to create the panels, all that kind of stuff. So we oversee the whole thing. It's a fairly involved process of creating clinical practice guidelines, if anyone's ever done it. So I don't know. Did you see my mouse here? Yes, no, any mouse? No mouse? Do you see my mouse here?
No, I don't see it.
You don't see it anywhere. Okay. I'm trying all my screens. So I'll just walk you through it. But it starts with developing a detailed protocol that we register. And then there's a systematic review of all the literature based on the terms in the protocol. We develop a panel that looks at all the evidence, comes up with recommendations. We work with the methodologist. Thank goodness. That's why it costs $100,000, because it's so much work. But we come up with recommendations. We have to circulate it to be approved by a committee. And also there's an open comment period for anybody to review the recommendations. And then there's a practice committee at ASCO that has to approve it. We have to address the comments. So it goes through the clinical practice guidelines committee. And the agreement is that they're all published in the Journal of Clinical Oncology, which is ASCO's flagship journal, very high readership. And finally because it's going through the ASCO process, we also get all of their PR, and we get all their additional resources too, which I'll show you. So the evidence ratings that come out from the system that they use is they look at quality of evidence and then strength of the recommendation. So the evidence is rated in terms of high, intermediate, low, or insufficient quality, based on specific criteria. So we go through all of the systematic reviews, all of the studies, we rate the quality. So strength of recommendation is also attached to each of the recommendations, so that they can be strong, moderate, or weak. So every recommendation has a quality and a strength that's associated with it. Sorry, my phone's ringing, but it looks like you guys can still see me, so I'll ignore it. Okay, so I'll take you through the pain guideline. So this one was published in Journal of Clinical Oncology in 2022. And you can see all the authors on it. So there was a big panel, and the way the panel is composed is that half the people are appointed by SIO and half were appointed by ASCO. So this came out in 2022 in September. It's been downloaded over 46,000 times. So it's making a lot of traction. And of course, we know, that pain is an important and common problem that can impact treatment outcomes and quality of life in people with cancer. And pain management is really complex, right? And it depends on the presentation. Like neuropathic pain is treated differently than musculoskeletal pain, and actually quite hard to treat. We have to take into account the duration of the pain, whether it's acute or chronic, and etiology as well. So managing pain has always been a difficult problem within oncology. And so some of the integrative therapies do have a contribution to make. So the objective of the guideline is to provide these evidence-based recommendations on specifically integrative approaches to pain management. So the guideline didn't look at any pharmacological approaches or anything like that. So it started in May of 2022 with developing the expert panel, lit searches, draft guidelines. We also consider implementability of the intervention, revisions for clinical practice, evidence quality, all this kind of stuff that has to happen. In this case, there were 227 relevant studies. What I didn't mention, but only randomized controlled trials are used in the process to inform guidelines. And that's a bit controversial as some of our practitioners and members, there's lots of other evidence, qualitative and observational and pre-post studies, but the guidelines only look at RCTs and only those that have a minimum number of, it varies by guideline, but either 20 or 50 participants in each group, treatment and control. So only using the high quality evidence. In this case, there was 227 relevant studies. Some of those might be systematic reviews, like in the anxiety one. A number of the studies were systematic reviews that themselves had 20 or 30 studies each. And then there's some form of informal expert consensus in determining the final recommendations and the strength of recommendations. So this is a summary of the recommendations table for the pain guidelines. And the way it's broken up is by category of pain. So the first category is aromatase inhibitor-related arthralgias or joint pain, which is quite common, mostly in women with breast cancer. And then general cancer pain or musculoskeletal pain, chemotherapy-induced peripheral neuropathy, procedural pain, and palliative care pain. And so you can see there's a small number of recommendations, and they're evidence-based mostly, some informal consensus. The quality of evidence is intermediate to low. There's really not a lot of high-quality evidence in this body of work. And so that means the strength of recommendations are, moderate or weak for most of them. But we can run through some of the key recommendations here. So the first one is that acupuncture. Oh, and the other thing about the way these recommendations work is the wording. So the recommendation can be, the strongest wording you can use is should be. So acupuncture should be offered to patients with AR-related joint pain, whereas the weaker wording is may be offered or should not, if you have a negative recommendation. So this one, acupuncture should be offered to patients with AI-related joint pain. This is based on 4 systematic reviews and 4 additional RCTs, intermediate level of evidence, moderate strength of recommendation, benefit outweighs risk, which is the case for most of these therapies. This is an example of one clinical trial that informed the recommendation. So let's see here, there was 226 people randomized 2 to 1 to 1 into 3 different groups. So true acupuncture versus sham acupuncture and waitlist control. So in sham acupuncture, everything's the same. It's the same room, it's the same practitioner often, or there's a number of different practitioners that provide the therapy. They put needles in, they just put them in the wrong place usually. And so people are fooled by the sham. They think they're getting the real acupuncture. But when you look at the responders with clinically meaningful change in pain, we've got 58% responders in true acupuncture, whereas the sham acupuncture is not that much different than the wait list. So this is one of the trials that was taken into account in making that recommendation. Another one is recommendation 1.3, and I'm not sure if this is a should or a may, but we could look. So acupuncture for general or musculoskeletal pain from cancer based on 8 randomized controlled trials. Again, intermediate level of evidence, moderate recommendation. This is a study here with 360 people, again in 3 groups. One was usual care, and here they compared auricular acupuncture, which is in the ear, and that's traditionally used for pain control in traditional Chinese medicine, compared to electroacupuncture, which is where they insert the needles and they hook a little machine up to it, where it provides a slight electrical stimulation. And so we can see that both the electroacupuncture and the auricular reduce pain by about 2 points, or 1.5 to 2 points compared to usual care. And they also followed people up here for 6 months and showed the effects were durable. And it was a large effect size with minimal toxicity. So that's one of the studies that would inform this guideline. Skipping ahead to palliative care, one of the recommendations is massage is effective during palliative and hospice care. So there was 2 systematic reviews. I don't know how many studies in those, plus 7 additional RCTs, again, intermediate and moderate strength of recommendation. But here's a big study of 380 people. And in this trial, it was advanced cancer patients with moderate to severe pain. And this is showing you a comparison between the massage treatment and control, whereas 0 was no change and, moving towards 1 being better. And so we could see that there were significant improvements on pain and less effect on mood with no side effects. So there was short-term pain relief and enhanced coping in the people with palliative care who received the massage. Another recommendation in another area of pain was procedural pain. And here a lot of the research has looked at hypnosis and shown benefit there. So that's one of the recommendations. And this is 5 studies with 2 larger RCTs. This is an example of one of them. So this is 200 people who were randomly assigned to hypnosis condition, empathy condition, and standard care. And this was just, I think, before like a biopsy in people with breast cancer. And so the hypnosis condition, it was just like a 15-minute induction, something like that, very brief. Whereas the empathy condition, again, was the same person or a similar person standing next to the person, the patient during the surgery and providing empathic comments like, it's going to be okay. I can see this difficult, but not doing any specific induction with hypnosis for pain management. And so you can look at the time, it goes up to like 3 hours post procedure. And you can see in the hypnosis group, so the first one is pain, and the second one is anxiety. The pain hardly went up at all in the hypnosis group, and there was some post-procedural pain in the hypnosis group, but then it went down again very quickly. The standard care, it kind of went up and fluctuated, stayed quite high. Interestingly, the empathy group did the worst. So that's an interesting just observation. And the same with anxiety. So the anxiety went down very quickly in the hypnosis group. It kind of went down in standard care and then kind of went up again in recovery when they're experiencing the pain. And the empathy group, it went down a little bit, but not as much. So in this case, actually, having an empathetic person there by your side was not beneficial, but the hypnosis was. And there's other studies as well in this area. The other recommendations were weaker, but there are recommendations, just weaker ones, for yoga as being effective. And typically, I think I might have a slide on this, but typically yoga interventions in oncology are something like twice a week for 6 weeks, maybe 12 sessions, or once a week for 12 weeks, that kind of thing. And it tends to be group-based and very gentle therapeutic yoga style. And also weak recommendation for guided imagery, music therapy. And really and I think the caveat for all of these, it doesn't mean that these therapies aren't effective. There's just not a lot of randomized controlled trials investigating the efficacy, not enough to make the recommendation, right? So it doesn't mean they don't work. It just means there's not enough research, or it hasn't been investigated. So along with all these guidelines come the treatment algorithms. So you've got the people with the pain, the different kinds of pain, and here it shows you, summarizes the integrative therapies. So the ones in green or blue are higher quality of evidence, right? So the AI pain, we've got acupuncture and yoga. The overall pain, acupuncture, reflexology, massage, yoga, guided imagery. And so we've sort of talked a bit about some of these examples of hypnosis and massage that have the higher levels of recommendation. So other things were inconclusive. So mindfulness-based interventions, specifically for pain, there's just not enough research. So they're, in the largest trial, there were no null effects. So it really didn't have a huge effect on pain. But there's other smaller trials that are showing effects of mindfulness-based interventions on pain. So there just wasn't enough evidence to make a recommendation there. So it's inconclusive. A similar thing for all the natural health products for pain. I mean, there's lots of studies out there trying different topical things or different, herbs and supplements, but there's just too many small trials, high risk of bias, many different products utilized, and just inconsistent findings. So they weren't able to make any recommendations. And they also looked at pediatric pain, but again, there wasn't enough research. So small RCTs, looking at procedural pain with hypnosis, music therapy, virtual reality kind of distraction techniques. But the quality of the studies was too low, or the sample size was too small, and high risk of bias. So they didn't feel confident enough to make recommendations on those. So these are areas that need more research for sure. Okay, so this is, again, a visual abstract that summarizes these recommendations here. So it's exactly the same information, just includes the type of recommendation, the quality, and the strength there. Okay, so I'm going to go from pain to anxiety and depression. So our second guideline, I led this guideline as a co-chair along with Julia Rowland, so is much more involved in this. And you can see the panel. If we were to look at this, you'd see there's all kinds of different people from different areas of expertise, and that's how we create our panels. And this is the guideline here that came out in August of 2023. Right now, we've got over 22,000 downloads on this particular guideline. And so we divided it into 4 clinical questions. So anxiety, during active treatment and post-treatment, and depression during active treatment and post-treatment. So we just divided them both up into during and post. Same kind of methods. We had the expert panel. We did the systematic reviews and meta-analysis and RCTs from 1990 to 2023. We spent a lot of time going over all the evidence tables. The methodology we use is called Guidelines into Decision Support, or GLIDES. In this case, there was 110 relevant studies, but 30 of them were systematic reviews and 80 additional RCTs. I think it was something about 400 studies that were included if we look at what was in the systematic reviews. So we've also got the treatment algorithms here. This is specifically for anxiety. And in the end, anxiety was broken down into active treatment, procedural anxiety, sort of like the procedural pain, and post-treatment. And I'll go through this in a bit more detail, I think. But what we're seeing here is that there are some green ones. The green ones are mindfulness-based interventions. So with strong evidence and high level of quality, is the only ones that get the green is the mindfulness-based interventions. And then we see yoga as well, specifically for breast cancer, is intermediate. Yoga for other types of cancers is lower, just because there's less studies and less evidence. We've got relaxation therapies, music therapy, and reflexology shows up here. Again, we see hypnosis for procedural anxiety, and even lavender essential oils can decrease anxiety. And then post-treatment, we see similar kinds of things. We're adding in acupuncture and Tai Chi and Qigong here, because that's where the studies with those interventions were conducted. Depression is just broken into active and post, and we're seeing the same kinds of interventions. And often it's the same studies, because people, usually if they measure depression, they measure anxiety as well, right? So a lot of these recommendations are coming from the same studies, but we see, high and strong for mindfulness-based interventions and intermediate for yoga. And then the other interventions have weaker recommendations. This is the visual abstract here that's just sort of lists all the different therapies that are recommended during active treatment and post-treatment for anxiety and depression. There's a whole bunch of inconclusive ones. Again, you might be wondering, some of your favorite therapies not showing up there. So these are ones that have research, but not enough. So music therapy and music-based interventions, nutritional interventions, light therapy, psilocybin, massage, dance movement therapy, laughter, healing touch, expressive writing, acupressure, biofeedback, autogenic training, energy healing, melatonin, other natural products. So we looked at all this literature, but we just felt there wasn't enough in these areas to make any recommendations. And in depression, it's a pretty similar list. So because the strongest recommendations are for mindfulness-based interventions, it's useful to define what those actually are, what we classified as an MBI. Many of you are familiar with these, derived from mindfulness-based stress reduction, developed by John Kabat-Zinn back in the late 1970s, detailed in his book, Full Catastrophe Living. They're designed to cultivate the capacity for mindfulness or present-centered, non-judgmental awareness within a framework of attitudes around acceptance, letting go, and awareness of how one's thoughts sort of cause suffering. Typically, it's an 8-week group class format with home practice daily. It's didactic content. It includes social support, home practice, components of inquiry into one's personal experience. So it's a multimodal kind of intervention. So MBIs are not just giving someone guided meditation scripts and sending them home. It's not using an app. It's actually a group interpersonal dynamic program. And that's what the evidence is suggesting. Okay. So sometimes people think, oh, it's just mindfulness. It's not. It's a mindfulness-based intervention using this format. So there are adaptations to MBSR, like mindfulness-based cognitive therapy, one that we developed called mindfulness-based cancer recovery. There's others that are specific to breast cancer or cancer that other therapists have developed. Basically, the outcomes are very similar. So we lump them all together and call them mindfulness-based interventions. But they all share those components, that they're group-based, they're multi-component, they include daily home practice, and go through many different elements of mindfulness as it applies to sort of both formal practice and informal daily practice. So for example, these are just the meditation practices we do in mindfulness-based interventions. So usually start with the body scan where the people are lying down, bringing awareness, interoceptive awareness to body sensations. We do traditional sitting meditation, walking meditation. So this is more a body-focused awareness practice. Open awareness to whatever arises is a more advanced practice that we get to. We use imagery, visualization. We cultivate self-compassion and loving kindness, and lots of other things as well are part of that type of intervention. And we also include, I don't have it here because these are meditation practices, but mindfulness-based interventions include yoga. And sometimes people overlook that. They include mindful movement. So it's typically very simple yoga, but in some cases, people have incorporated more elements of Tai Chi or Qigong, but there's mindful movement practices in MBIs as well. And so the second strongest recommendations are for yoga interventions. And as I said, these are often derived from hatha yoga with restorative or therapeutic practices. There's many limbs of yoga, and many yoga practitioners, don't differentiate between meditation and yoga. So for example, there's ethics and duties one has as a member of society. There's different meditations, there's the postures, and I've highlighted the asanas and the pranayama, the postures and the breathing, because these are what's usually focused on or included in these yoga-based interventions in the studies. So typically 8 to 12 weeks, once or twice a week. So that's what the recommendation is referring to. A caveat on limitations really for any of these interventions. It's, when we look at a risk of bias, it tends to be quite high risk of bias, and there's many different reasons for that. I think a more important consideration is standardization of therapies. So, we lump lots of different things under, say, yoga, that are quite different. They may be different modalities, different lengths, different instructors. So these therapies are not standardized in many cases. So we may lump them together, but they could vary quite significantly, especially things like creative therapies or music-based therapies. There's huge variability. There's lack of diversity in study populations across this research. Middle-aged, more educated, white, Western women predominate. So there's very little demographic diversity, and also the types of cancer. They tend to be more focused on women with breast cancer. We don't see a lot of studies in other types of cancers. We don't see a lot of men. We don't see a lot of low-income people. We don't see a lot of ethnic or racial diversity. There's also the issue of what are we using for our comparison or control condition. So yeah, these therapies are better than inactive or usual care controls, but pretty much anything is. So the time has come to compare, I think, more active interventions against one another to see if we can determine specificity around some of these mind-body therapies, compare them perhaps to pharmacological therapies for, anxiety, depression, pain, that kind of thing. So we need to think a bit more closely about what our comparison groups are. And we also need to think about, okay, we've got recommendations on these therapies. We know they're beneficial in the studies they've been tested in, largely in person. So how can we enhance the reach of these therapies? Using digital health interventions, using more real world, pragmatic, implementation-based, practice-based research methods with including patient perspectives, patient-oriented research methods, and can we be more specific in terms of precision integrative oncology prescriptions, right? Like depending on your symptom burden and other characteristics, we may be able to identify like what therapy is going to be most beneficial for an individual. We are not at that point yet. Okay, I'm going to turn to the fatigue guideline. This one came out more recently, just in May. And it's been downloaded over 16,000 times. Now, this one's a little different because this is all fatigue, all interventions. So it's not just focusing on the integrative interventions for fatigue, it's looking at everything. So psychological, pharmacological, mainstream, integrative, it's all in the one guideline. And so SIO had a few members on this panel, but it was led through ASCO. What's this? So it's the mainstream guideline, as I said, combined psychosocial, integrative, and pharmacological treatments. And this just sort of shows you the number of studies in each area. So exercise, there's 40 RCTs, psychosocial and mindfulness interventions, 32 RCTs, other integrative medicine interventions, 24, and they looked at 18 RCTs with drug therapies as well. And we see the similar kind of treatment algorithm. So we've got it broken down into active treatment, after active treatment, and sort of more post-treatment, like down the road, because we know fatigue lingers for a long time in many people. And so what are we seeing? The strongest recommendations are for exercise, aerobic resistance, or a combination, as many of you may know, and cognitive behavior therapy with or without hypnosis. Mindfulness-based interventions also make it into the mainstream recommendations, as do Tai Chi and Qigong interventions, and lower strength for psychoeducation. And the only natural health product that made it in any recommendation here is ginseng for fatigue. And so we see similar kind of recommendations post-treatment, adding in yoga, some acupressure, moxibustion, which is a type of kind of massage. And post-treatment, we see CBT, and the only drug that makes it in anywhere is corticosteroids with very low recommendation post-treatment. So this is a summary of the fatigue guidelines here. There's also a section on interventions clinicians should not recommend for fatigue, and these are mostly drugs. So wakefulness agents, psychostimulants, L-carnitine is sometimes thought to help, but in the research it shows it doesn't have any help. In fact, it may have negative effects. Antidepressants should be avoided. And this is both during active treatment, post-treatment, and after active treatment and post-treatment that, wakefulness agents, right, like the kind of stimulants and that kind of stuff should not be used at any point in time. The only drug, as I said, that's in the recommendations is corticosteroids post-treatment, and I'm not sure how much evidence that's based on. All right, so those are the recommendations from the guidelines. We're working on the sleep one now, so it'll be interesting to see what comes through there. And now I want to share with you some really great resources that you can use yourself or you can share with your teams for getting learning about these recommendations, interacting with them, and also we have continuing education credits you can get. So the question is, great, we've got these guidelines, they have these recommendations. How do we get from recommendations on a piece of paper to actually people accessing these therapies in the clinic? So there's a number of different ways that ASCO routinely adapts these guidelines to reach clinicians, and one is a summary Q&A article that's published for each guideline in clinical oncology practice. So it's a briefer. If you look at the guidelines, they're ginormous. Like I think mine was, I don't even know how many pages, it's huge. But this is sort of a brief summary in a Q&A format that goes out to clinicians. And then there's clinical tools and resources that ASCO produces for every single guideline. So you've seen some of them in the presentation. There's those clinical algorithms, the sort of decision algorithms. I showed you the visual abstracts, and there's the summary of recommendation tables. There's also a podcast that's produced each time with the guideline co-chair. So Julia Rowland did it in our case. There's patient information that goes on cancer.net. There's a whole slide set that summarizes the recommendations that anybody can download, and you can just pop those slides in any of your own presentations. They're all available. If you just look up the guideline, they're all on the JCO page. This is an example of one of the evidence tables for anxiety and depression. And again, it just sort of summarizes in a easy to read, easy to capture format. So I think this is anxiety, this is depression, anxiety. Oh, I see. Wait. I see. So it's showing each of the clinical questions. So they overlap. So anxiety during treatment, anxiety post-treatment, depression during and after treatment. The podcast on the anxiety and depression guidelines, as I said, was done by Julia, and that's available, Apple Podcasts, ASCO Podcast. The patient information on cancer.net is updated with each guideline in a way that people can take in, and lots of patients go to this. So this is hosted by the American Cancer Society. So those are all there online. So anxiety and depression. I mentioned the slideshow. It's there in PowerPoint and PDF formats, and anyone can download that and use it in your own presentations. And the really neat thing that SIO has done, so those were all done by ASCO. And they're good. It's nice to have those things. The slide decks are a little bit boring, but they're comprehensive. But SIO really wanted to create more resources that could be used by clinicians in a practical way, in an interactive way, and that they could get continuing education credits for. So we got a grant, and we partnered with an expert on continuing education and made these really cool training modules. And so we have them now freely available on our website for the pain ones and for the anxiety ones. And I'm going to show you a demonstration of what it looks like here. Okay, let's see if this works. I might have to go out. Let's see. Okay, are you seeing the web page? Yes, you are. Good. So the training modules are here on the SIO webpage, and we can do anxiety, depression, or pain. And well, let's just like kind of work through it. I'll start with pain. And so if you click on it, it shows you the different types of pain, right? So we can do introduction, AI, joint pain, general pain, CIPN, procedural pain. So we can click on any one of these. So let's just maybe go to general pain. And if there's something specific you want to look at, just tell me and we can do it. So you can start here. If we click on start, it takes you to, you can see the outline here on the side, right? So there's acknowledgements, who made them, an introduction, what is pain. The recommendations are summarized here. So you can click on any specific modality to get the recommendations for it, or you can click on the modality on the side. So let's try reflexology, which is a little bit different. Oh, that summarizes it there. Oh, I see. So it summarizes which recommendations include these modalities in this section. And then to learn more about each recommendation, you can click here and all these tabs come up. So for each therapy, there's an overview of what is it. So here for reflexology, it explains it. You can click on that and see the chart of all the different places, all the different areas that map on. And it summarizes the evidence. So how many RCTs, summarizes some of the studies there. There's some acupressure here below too. So reflexology and acupressure are kind of together. And then there's a tab on safety and practical things. So how do you train providers? How can you find a provider? And then the same thing for acupressure here. So, it talks about what's acupressure. You've got a map of the meridians you can look at. What's some of the evidence, safety, practical stuff. So that we have that for every single type of pain. And you can look at every single modality. So guided imagery. And it gives you the overview, the evidence, the safety, and the practical. And then for each one, there's a case study. Let's see what happens here. So Carlos was introduced at the beginning, and so then you can look at his situation and look at the recommendations. And you can type it in and see what happens. So it's very interactive and kind of fun. Does anyone want to look at any of these other pain ones before we go to anxiety? Okay, well, we can go to the anxiety ones. So here's the modules. So again, we've got active treatment, post-treatment, procedural anxiety. So say we go to anxiety post-treatment. We can start the module. So acknowledgements, introductions, what is anxiety? How common is it? There's our case. Tells you about the sort of case, introduces it here, and what she's going through. Summary of the recommendations here in the table. And then it goes through the different modalities. So here for mindfulness, and there's quite a few of them have videos and stuff too, like the acupuncture one has a lot of good videos. So what is mindfulness? I don't know if I shared sound, actually, I probably didn't.
Hi, everyone. My name is Dr. Ashwin Mehta, and I'm the medical director.
So I think this one has me, yeah, so I'm describing it.
Many different adaptations of the MBSR.
So there's videos as well, and the evidence quality, and then the sections. So overview, I wrote a lot of this material, like what's a mindfulness-based intervention, summarize the research, the different types of MBIs there, summarizing some of the evidence for the different recommendations, safety. There's also practical, where you can find resources, another video about misconceptions, how do you find a therapist? And there's some cool stuff in acupuncture too, like that, like quite a few videos. This one's cool. Here, if you guys want to hear this, I can just reshare it with sound.
We can sit, we were able to hear before, so you
Oh,
can.
could you?
Yeah,
Okay.
yeah.
This acupuncture one's kind of cool.
Acupuncture is used to treat a range of symptoms commonly seen in patients undergoing treatment for cancer, such as nausea and vomiting, dry mouth, and pain. Acupuncture is a centuries-old practice and therapeutic component of traditional Chinese medicine, or PCM. Treatment involves the use of very thin needles to stimulate acupuncture points, called acupoints, on the body, promoting the flow and balance of internal energy, or qi. According to TCM, there are over 360 acupoints distributed along 14 major meridians, or energy channels, in which energy flows through the body. Acupoints are high-density neurovascular structures that display low electrical resistance. They are generally found between or at edges of muscle groups. Acupuncture is usually performed while the patient is lying comfortably. Based on the patient's presentation and symptoms, the acupuncturist will select several acupoints that address their condition. Once the acupoint is located, the acupuncture needle is inserted at a depth to elicit the qi sensation, which is a feeling of soreness, achiness, heaviness, or numbness. Acupuncture needles are very thin and are inserted with little or no pain. Once the needles are in place, there should be no discomfort. The needles remain in place for 20 to 30 minutes while the patient rests comfortably. Patients often say they feel very relaxed and even fall asleep during treatments. A typical course of treatment of 8 to 12 sessions achieves the therapeutic effect. Chronic conditions usually require additional courses. It can take 4 to 6 sessions to see improvement in symptoms, at which point the acupuncturist will assess a patient's response to determine whether acupuncture is a suitable therapy. With electroacupuncture, wires are clipped to some of the needles and connected to a device that delivers a low-voltage stimulation to the needles, similar to a TENS machine that patients may be familiar with from physical therapy. With manual acupuncture, the needles are stimulated by hand.
Okay, how do I get out of this? There we go. So that's an example of some of the content on here. I think there's also some really good stuff. Yeah, there's another video, so it's not all just reading, it's interactive, and this is, the practical aspects. So he talks about, is it covered by insurance? Is it safe? What happens? Does it hurt? Just addressing sort of some general concerns. Okay, so I don't know how to go back. Well, there we are. Just back to the slides here. I think I'm just about done. So just to summarize, integrative oncology is a growing subspecialty of cancer care. Includes lifestyle modifications, mind-body therapies. Many therapies have a strong evidence base for treating different symptoms and side effects. And these clinical practice guidelines and implementation tools that we reviewed are freely available. And of course, we just reviewed that recommendations include access to therapies like acupuncture, mindfulness-based interventions, yoga, and others. So I'll just finish by once more promoting SIO, and our conference this year is in Boston at Dana-Farber and Harvard, October 27th, 29th. Call for abstracts is going to be opening soon, so it would be great to see more psychosocial oncology people involved, actually, because we're kind of a minority in that society, and we have a lot to offer. So that's just some contact information for me specifically. Right, that's it.